First, thank you to everybody that is still here in this very interesting session, but I think that the hour is not the best one. You will see that my cases are quite different to the cases presented before, because when Antonio expressed me the interest of talking about this theme, when I think in neglected cases, I'm thinking in people that never has been treated, absolutely neglected. And my cases are these kind of cases. Neglected graft food, as you understand, as neglected from the birth, is really uncommon, common in developing nations, but is uncommon in Europe. Nowadays, sometimes it's increasing because of adopted child or for immigration, but it's not a very common situation. And you know that the Ponseti graft food treatment has demonstrated the high efficacy in treatment in current graft food, but and can avoid extensive surgeries in those kind of feet. And my experience is based in previous experience of other groups like the Egypt group, Brazilian group, and Indian group that tried to treat older people with graft food with Ponseti technique, and they show good results with that. And my history begins when a group of Spanish doctors that are working in India with disabled people asked me to do a Ponseti program in this rural part of the India. It's a very poor zone, and I began to collaborate with them in 2009. And we have to do a Ponseti protocol, including in those neglected cases. And we need an accelerated protocol because we have only 1 month to act there. I just was there for 1 month, and I based my accelerated protocol in the previous published papers that demonstrate that you can use a plaster for 5 days and you can get the same result. So my experience in treating neglected graft food, and this is the reason because I am here, is because it's not one case, it's not 2 cases, 46 feet that were treated with this Ponseti fast protocol, and I will show you some of these cases. This is the first case. This is a case that is not from India. This is a case that was treated in my hospital, and is one of these cases that are adopted. This is Elias. He's a boy of 4.5 years old. He was born in Morocco and adopted 6 months before this visit, and he had a bilateral graft foot. The left one was operated in Morocco, and when he arrived to my clinic, has a very mild relapse of the deformity, and with the scars typical of for the villa posterior medial release, and the right graft foot has never been treated. And this is the left graft foot that with the scar was treated at the 6 months of age and has a little bit adductor scabos, but I feel that I can correct it manually. And this is the right foot that was completely neglected. As you can see here, there is a crease that is crossing all the sole. This is the typical complex or a typical graft foot, as if you know the Ponseti classification, and was quite stiff. This is the scanner that I perform on the X-rays. I don't use too much the X-rays to analyze the cases. I use my hands in most of cases, but in that case that was in the hospital, I can do that, and I use the X-ray to get more information. And this is the boy when he arrives to my clinic. He can just stand up and walk with not very good stability, and he tries to run because he's a baby, and all babies try to run and walk, but she falls down very usually. And what do you think that we can do in that case? I plan these questions. It's not an exam, it's just to get your opinion. Treat just the neglected graft foot or treated and neglected, and the other one that is beginning to relapse in the same anesthetic procedure. Apply previous Ponseti cast to that case, and to do a release, a big release or bone surgery in that case, or just tenotomy, transfer, or small surgeries. What do you think about the first question? How many of you treat just one or both? One? Both? Okay. Apply Ponseti cast. Almost all of you. And any one of you will suggest bone surgery or releases in those cases? No. Those are my answers. I will treat both. I know I never treat one. I will apply Ponseti cast, and I never will suggest bone or releases in that case. And this is what we do in that case. We put 3 casts in the right foot. We have to change the maneuver. You see that this is the maneuver that we use in newborns for complex crab feet, pushing up all the metatarsals because all of them are down. The right foot was really difficult to cast because it was really stiff. I think this was one of the reasons, because nobody wants to touch it in Morocco. And I just need 1 cast to prepare the left foot for the transfer. These are the situation with the cast previous the surgery, with both feet pointing in external rotation in abduction of 40 degrees at least. And what will we propose to do in that case? How many of you will do complete Achilles tenotomy in that case? Percutaneous complete Achilles tenotomy. You. I know why. Because I was talking with you. Any one of you will think that this case will need posterior capsulotomy? Okay. And some of you, do you think that this case could be solved with anterior tibial tendon transfer, with anchor, or with tunnel? Do you think that this is a good idea? I will do a complete Achilles tenotomy in both. Non-posterior capsulotomy was needed, and I will perform anterior tibial tendon transfer with anchor in both feet. This is the surgical images. How we do. We perform a percutaneous fascectomy also in both cases. Capsular stretching to get dorsiflexion after the tenotomy, and the anterior tibial tendon transfer to the third cuneiform under the skin without opening any extra scar. And in the left foot, we perform Achilles tenotomy in the scar, fascectomy, and anterior tibial tendon. 4 days after surgery, this is the situation of the boy. We remove the long cast and we put a synthetic short cast for walking with weight wearing. And this cast was wear for 1 month. And after removing the cast, we put a DEFO, a dynamic ankle foot orthosis, because the anterior tibial tendon in those cases usually has not been working very properly before, and you can help them with a dynamic ankle foot orthosis to avoid the equinus deformity. And this is 2 years later. This is the situation. The baby was asymptomatic. The feet has a good correction. He can walk without any problem. He is doing sports for the age, and he's wearing normal shoes. And this is the video of Ilias 2 years after the surgery. He can walk, and he can run in my clinic. That is very small, but he's running very well. This is the results of Ilias.
You had no problem for a complete Achilles tendon?
No, he's recovering and he can walk on hills and and tiptoes without any problem.
What do you mean with total?
Total.
You cut it.
Cut
But
percutaneous.
you don't cut it in two
No,
levels and
total.
slide.
The total.
No set lengthening,
No.
So do you think that is maybe
In craft food, you can cut totally the Achilles tendon when you want. In craft food, not in other pathologies.
How many plasters did you actually do to get some correction?
In this case,
Yeah.
3 in the right, that was the worst, and 1 in the left.
So just 3 plasters.
3, yeah.
How many needs do you? Why didn't you go for the full? For 6 plasters as the Ponseti say? So what make you decide that I can't go any further? So I have to do surgery now.
When I get 40 degrees of abduction, I can feel how it moves, how I can move it. And when I get 40 degrees of abduction with the cast, I know that this foot can be done, the Achilles tenotomy, because the heel is neutral or valgus, and you can do the transfer and it will work. This is the sign to get 40 degrees of abduction. For a transfer is enough. If you are doing the treatment for newborns and you just do the tenotomy and braces, you need 60. In those cases with anterior tibial tendon transfer, usually I don't use. In cases of my hospital, if I have the possibility of physiotherapy, it's good. But in Indian cases, as you will see, I cannot use it. In Spain, if a family has the possibility to go, I will help them with physiotherapy to improve the anterior tibial tendon strength. No.
He was 4 years old.
No, just a day for to work. So this is the next case. This is quite challenging. Is a boy, 19 years old. This is one case of India, of course. This is not a Spanish case, and this is one of the cases that I find the first year I went to India. So this is the number of the register. He has never been treated. He arrives to the clinic, to the workshop in this situation. He's a student, and he has a craft foot that never has been treated before. I feel how the foot is moving, and I feel that I can correct this case. You have to know that when the first year I arrived to India, I cannot do any bone procedure because it was forbidden in the hospital because of the risk of surgery. So I just can do tenotomies and transfers. That was all I can do. So I talked with the boy. I explained that it was a possibility of improving the foot just with plaster, tenotomy, and transfer. That I know that previous experiences helped to believe on it, and he was thinking on it. You see that this was the 24th, and it was 24. He was 3 days thinking if he wanted to be casted or not, and finally he arrives to the workshop and says, "Yes, I want to try to get improved." The first cast was a short cast because he was a student and he thought that he cannot manage with crouches and with long casts. And okay, what do you think is too old to be enrolled in the Ponseti protocol? How many of you do you think that is too old? Okay. And how many of you do you think that the correct way is to do a long cast if you want to do anything? Okay. Those are my answers. This boy is not too old. And I did a long cast. So after the experience of the boy, when he comes to the clinic and I remove the foot, he saw how the foot was improving. And then he allowed me to put a long cast because I explained him that was better. And this is the second cast. After the second cast, and this is the third, this This is one of my technicians that helped me. They are very enthusiastic in India, and they can do the cast now after the training. And what do you think about surgery? How many of you suggest to do a complete tenotomy? No. Posterior capsulotomy? Okay. Anterior tibial transfer with ankle? Okay. And I haven't explained you, but I don't know if you have seen, this boy has 6 tools. How many of you do you propose to resect the 2?
I think they have some religious matter. They won't let you do that.
Good, very good. This is what I think. I perform a complete tenotomy. I didn't think in posterior capsulotomy. I perform an anterior tibial tendon anchor, and I asked to the boy if he wanted to be resected this too, and she said me, no, because it's lucky for my family, and I don't want to be the 2 resected. And this is what I perform: anterior Achilles tendon, Achilles tenotomy, percutaneously, fascectomy, and transfer. This is the cast after the surgery. And this is 2 months later. Yeah, 2 months later. No, 1 month. 1 month later after removing the cast. It's because it's changed the position. And this is how it was. He was really happy with his new foot, but this is maintaining in the time. It works, because I don't know, I can show you a picture of 1 month later, but what happened with this boy? In India, it's really difficult to do the follow-up. People tend to disappear of the clinic. But curiously, 2 years later, in my 3rd visit to India, the day before I leave India again, he appears to the clinic. This is the previous situation. This is in 2011, 2 years later. He was absolutely happy with the food he's studying. He's doing all the activities normal for the age, and he's asking for excision of the 2 because he's having normal shoes to the school, and the 2 is a problem for him. This is what happened in that case. And this is the last one. This is quite short than the others, because I think that you now know my tendency, so there are no secrets for you. But this case has something special, that is a 15-year-old girl, but she has an arthrogrypotic syndrome. It has both upper limb affected and very stiff feet, and she cannot walk. She has just standing with the feet. She's walking with long crouches to moving in short distances. And it was in 2010. We tried to correct her, of course. We have only time for 3 casts. We performed 3 casts. And these are more questions. Make sense to do casts in those cases?
Mm-hmm.
I think yes. Do you think that you have to do a complete Achilles tenotomy? Especially in an arthrogrypotic case. Posterior capsulotomy? Yes. Anterior tibial tendon transfer? It works. So I said, I can try it. You know that in arthrogrypotic club foot, sometimes you don't have a very strength tendon, but it works in that girl, so I did. And do you think that she will need bone surgery?
Yes.
Probably. In the first year I treated her, I have not the option. So these are my answers. And the only thing that I didn't do was the posterior capsulotomy, because in arthrogrypotic feet, as much you open the joints, as much stiff will be in the future. So what we do was a 2 stages surgery because of the infrastructure I have, not because it was my choice. And first I performed a percutaneous tenotomy and the transfer. When we perform the tenotomy, you will see that it was a breakage of the skin, because the skin was so tight that I can move the foot, because I cut the tendon, but the skin was open. And I performed a second stage with osteotomy in the second year. The third year I was in India, because I was able to do osteotomies. And this girl was quite improved, but she has still a quite important adductors of the midfoot, and I perform a midfoot osteotomy, especially because I don't have too much material of synthesis in India, and I just can put key wire or just maintain the osteotomy with the cast. So this is the result in 2012. She was plantigrade. There are no zones of calluses in the soil, and she's walking with EFORT but without crouches. So in conclusion, I think the Ponseti protocol can be safe and effective, an alternative to treat neglected graft. It can be applied in all babies and young adults. It can be used to help surgeons in very stiff cases to do a not so aggressive surgery. And the limit probably is the age and the stiffness, like those cases of 32 years old that I feel, and I feel that the foot is not moving at all. So I propose it for bone surgery. I have to operate next time I will go to India. So thank you for the audience, and thank you to Dr. Ponseti, that was the author of all this matter.
Comments, questions from the floor?
My comment is that I have to leave you because my taxi is waiting.
Yeah.
So I am very sorry. Thanks.
Have a safe trip.
Thanks for great cases. It was so fun. Thank you. Bye.
Anna, thank you for this great experience.
Thank you here.
I was wondering, you never used the Pudvilla sole or
No.
the transfer sole? Never.
Never in my life since I discovered Ponseti technique and the transfer.
You can manage everything.
Including in post-operated cases with relapse. You have a paper in the clinical orthopedic related research that we performed with Monica Nogueira and Cristina Alves. It's a multicentric study, and we use Ponseti technique in that way in relapses after posterior medial releases, including cases that have been 4 times operated before arriving to the Ponseti protocol.
Okay.
What's the rationality of the DFO?
The DFO, yeah, it's a dynamic. So it's a orthosis that allows to do dorsiflexion and not to do plantar flexion. This is because I have observed that in some cases, especially in neglected one, that the tendon has never worked properly. The Achilles tendon that you cut completely heals before the anterior tibial tendon works properly. And sometimes you can have a relapse of the quinus because the anterior tibial tendon is not heavy enough to fight against the Achilles tendon. So it's a good idea to put the brace, the orthosis, to not allow the Achilles tendon to push down and to help the anterior tibial tendon to work better. This is the reason. Any more comments?
We close the session. Thank you for being
Thank
here
you.
so late.